Can you see the screen? Can you see the screen? Hello?
Yes, sir. Yes, sir.
Yeah, okay, fine. So, who's taking this? Someone start off.
Sir, actually, we able to see only the blue folders, like not the.
You're not seeing the picture?
No, sir.
Array. Okay. Now,
Again, the blue screen only. The
still
blue
not
folder.
seeing?
No, sir.
What happened then? I thought I was opening this thing. Let me make this full screen. Okay, let's see now. Now?
So only the blue folders are visible, like no.
Oh my God, why is this? Your screen screen sharing is paused.
Okay.
Now, why is this? Resume share. Okay. Again, it is saying it's paused. Still not seeing?
No, sir.
Resume share. Stop share. Share screen. Now?
Yes, sir. Now it's seen. Yes. Sir.
Now it's in. Okay,
Yes.
fine. Fine. So let's start with this.
Yes.
The plain radiograph.
Yes, sir. Sir, this is a plain radiograph of the abdomen with a contrast study, showing delineating the left kidney. It's an IVP study. The left kidney shows multiple blobs of contrast within the kidney, with no draining, distally.
Is it contrast study only?
Um,
Is this contrast that you're seeing? Some are so light, some are so dark.
so they're okay, sorry. Okay. Sorry. So, sir, are these calcifications? Sorry, sir.
These are not. This is not a contrast study. Maybe you are seeing some contrast also,
Okay.
but of an IVP thing. But this is. It shows you, yes. What region is it?
So, so it's the left hypochondrium.
You know, it is showing you except the bladder area, the kidney and the ureter area, most of it. The lower
Yes, sir.
part is missing.
Yes, sir.
Right. So lumbar area, it is actually showing you the renal areas.
Yeah.
And
Yes,
then you are seeing bony shadows and this thing. It's an AP view or a PA view?
so it's an AP view because the
AP view, yes, prominent
Yes.
spines.
Yes,
Right.
sir.
And then you are seeing so many radio opaque shadows.
Yes.
So many small radio opaque shadows. Then this is one large radio opaque shadow. This is
Yes, sir.
another radio opaque shadow. Now you must tell me more about these radio opaque shadows.
So there are multiple. Multiple radio shadows in the left kidney, suggestive of multiple radiopic stones or.
Yes. So it's very clear, no? You see upper calyces, middle calyces, lower calyces.
Yes, sir.
And then there is a big pelvis shadow here.
Yes, sir.
So you see what are the type of stone here? What are these types of stones? These are
So this,
calculi, radiopaque calculi.
yes, sir. So, in the pelvis, a stagon calculi is seen.
Okay, typical stagon.
And
Then there are multiple calculi in the lower calyx here.
yes, sir.
What type of calculi is this?
Sir, a dumbbell shape.
A dumbbell. Yeah. What is the importance of this dumbbell calculi?
Uh,
Is there any surgical importance for you to know when there's a dumbbell calculi? Is removal of this dumbbell calculi easy or difficult? It is difficult because this is going through one space, going through a narrow ostia and then another one.
Okay, sir.
So when you remove it either from this side or from this side, it tends to break here. So that is a technical problem in dumbbell calculi.
Okay, sir.
Removal of this calculi will of course be easy, relatively easier. What
Yes.
about these calculi?
So there are chances of like leaving a few calculi within the.
Yes. So how will you manage these problems intraoperatively? Suppose you were to operate on this child.
Okay, sir.
Do you want to operate on this child or do you have some other means of removal?
Sir, in such huge calculus, we'll have to operate on the child. Like,
yeah, these are large and variety of calculi. So it may not be amenable to one particular type of ESWL or all those things. So you might have to need to operate this child. So before you operate this child, what sort of other investigations would you do?
So we'll have to do a metabolic workup of this along with like even the calcium levels, the oxalate levels.
Right. So you will do a metabolic workup to rule out any metabolic disease so that you can counsel them accordingly. So if would a metabolic disease like this cause only on one side?
No, sir.
So rarely it can cause, but usually it is bilateral. So that is the difference, because on the other side you don't see anything, not even nephrolithiasis, besides this calcification stones.
Yes.
Okay. So suppose you are operating this, how would you change your, or how would you do your surgery? You would take out the pelvis, yes.
Yes, sir.
Then?
So the first we'll have to take a long pelvic incision to remove the stagon calculus, because although it's in the pelvis, it's even abutting within the calycis, some part of it. So
yes,
it's difficult to removal. And
so long pelvis incision in the longitudinal axis of the pelvis or some other way?
Sir, usually the longitudinal axis only.
Okay. So, but you would need to sort of lift up near the renal, those margin there with a Gilvanet retractor or something to be able to see there, like an eyelid retractor, to be able to take it out from the thing, right?
Yes.
After that thing is over, the rest, taking out the lower calyces one.
So the lower calyx is like with a stone retracting forceps or with
and flushing, etc. And then intraoperatively, what would you be careful so that you don't have retained stones?
So like we'll palpate over the cortex of the kidney to feel for
palpation. Yes, that is something more fine than that which you can employ.
So like we can use a long tooth or a fine forceps just to palpate the stones if we could.
Radiology.
Okay, like under a C-arm we'll have to do.
Yeah, so both a C-arm can tell you whether you are completely done, and an ultrasound also might be useful to a certain extent to tell you that yes, you have taken out all these radiopaque thing or not. So that is how you go about.
Yes, sir.
Right. Before you go in for this study, will you do some other tests?
So like routinely, even we'll have to do the urine analysis, like for
Right. Yeah, a metabolic workup you said you will do. Anything
Yes.
else would you do?
Uh,
Something else? Would you want to know the function, if there's any function there?
so, but then like with such large stones, already the kidney is going to be like
Correct. So
obstructed.
you would want to know whether there is any residual function or no residual function. Suppose this is a non-functional kidney, then you would not be going on doing all these things.
Okay.
Right. So always
Yeah.
think from management point of view when they're asking you, and start from the basic things. It's good that you started from metabolic workup. That's a very key concept in
Yes.
stone disease in children that way. So
Okay.
similarly, function, because you are trying to retrieve, restore this kidney or salvage this kidney. So there should be function for you to
Yes.
salvage.
Okay.
Okay.
So
Right.
just one thing, like if
Yes, yes.
it's if it's like a very less function in this kidney, so like, or if it's non-functional, so we'll directly, like we should plan for nephrectomy, because like even in
Yes.
severe cases, we give a chance for like survival of the kidney. So
No,
after
if there is absolutely no function on your DMS, a renal cortical scan,
Okay.
so that means there isn't any function there at all. And clinically, what would you see in such a child who has stones, who probably has very poor or no function? What's the other clinical parameter that you will see?
Uh, so like growth failure or like periorbital edema,
What else? Hypertension.
hypertension. Okay.
Yes, right.
Yes. Sir.
So can we go on to the next one? Can you see this on the screen? Next person.
Thank you, sir.
Yeah. Yeah. So who's taking this next? Please identify yourself. Yes. Anyone?
Recording in progress.
Come on, someone take this up, otherwise we'll be stuck. Exam going students, come forward. No one? Okay, then I think we'll ask someone. Maitreyi.
So I will try to read this.
Sure,
But-
sure.
So this is a special contrast study. Hello?
Yes, yes. Go ahead.
So the voice is echoing.
One. I'll just put this off. Yes, go ahead now.
This is a special contrast study of the lower urinary tract done in the retrograde fashion. I can see a contrast medium delineating the whole of the anterior urethra and the posterior urethra along with the bladder.
Why did you say retrograde?
Because it is most
When
done
you do
from
a retrograde study, is it so easy to opacify everything so well? The full bladder and something there and all? It's not easy. It's not easy. You have to overcome sphincters here, there, everywhere to do it. So
yes.
it's not easy to do in a retrograde study. So unless you have one catheter there which you're seeing or something or some strong reason, such a well delineated bladder, you will not see in a retrograde study. So this is an MCU.
Okay, yes, it's a MCU.
Yeah, go ahead.
Yes, sir. So I can see delineation of the anterior urethra, the posterior urethra, and whole of the bladder. Radio opaque shadow is seen originating from the bulbar part of the urethra in a fashion like a diverticulum from the bulbar part of the urethra, extending posteriorly.
Where is the bulb? Bulb is where? Bulb is here. This is a vertical part of the urethra. This is
Yes.
where it
This
is
is the bulb.
turning, and this is the bulb,
So,
isn't it?
uh,
So it's a
from the
little,
portion,
little
of the-
above than the bulb.
okay, little above.
Hmm. So somewhere in the prostatic membranous urethra, somewhere there. That's where it's taking up from, the
Yes.
vertical part. Yeah, then
So the the divertical the diverticulum seen is smooth walled, large in size. Ureters cannot be delineated in this study.
okay.
Uh,
What is the position of this diverticulum that you are describing?
uh, Retroprostatic means it's between the rectum and the urethra.
And the bladder, you mean? This is a bladder.
Yeah, in the bladder and the rectum.
That's a bladder base there.
Yes, sir.
So which area is it related to?
Neck, bladder neck.
Bladder neck is here.
Yeah, below, like it's prostatic part of the urethra.
No, prostatic part of urethra is here. That's where probably it originates from. But what is it related to? What is this area which is
Semen,
related? What is this part?
So the trigone of the
It's related to the trigone,
Okay.
isn't
Okay.
it? It's related to the trigone. Okay, so this is the structure and it is opening here. So what is your differential diagnosis? What structure do you think this is?
So
Yes.
diverticulum.
Okay, yeah, you said diverticulum. What type of diverticulum? It's originating from the prostatic urethra or somewhere else, somewhere there. So what diverticulum is it?
Uh,
So what originates there from the prostatic urethra and or the lower prostatic urethra goes up there and is related to the back of the bladder.
Ejaculatory ducts.
Okay, anything related to the mesonephric duct will sort of be there, isn't it?
yes.
Paramesonephric or the paramesonephric duct, because they are the ones open there. So it
Yes.
can be either from the vasal thing, then it would be on two sides or in the midline. So what is the other thing that opens there in the midline?
prostatic.
Artericle, yes, the prostatic artericle. So it can be a remnant of that. So this is a typical position where you find a persistent,
Prostatic urethra.
yeah, or a Mullerian derivative. So what do you think this is? This is, can you make out, is this a male, female? What is it? What it is?
It's a male.
Male, the typical male urethral anatomy and a persistent structure there looking like a persistent Mullerian remnant, right?
Yes.
How do you investigate this child?
I will do
The child is
ultrasound.
presented with recurrent urinary infections.
Yes. So after doing basic USG study, I will plan for cystoscopy for this child.
Yeah. Okay, you want to do a cystoscopy, ultrasound you want to do, and then a cystoscopy. Okay.
Yes. Then I will, on depending on cystoscopic studies, I will
What exactly do you want to see in the cystoscopy in this child?
The origin of this diverticulum.
Okay.
Like,
Yes.
and
Where it is originating from, its relationship to the verumontanum, is it on top of that?
yes.
Confirm that it's a prostatic article. If you can enter it, if it's large enough for you to enter, you can see what's inside also.
Yes.
What do you think will be inside? What might you find inside? If it's actually a Mullerian remnant?
So then the musculature, uterus musculature, I will see.
That how can you see on the surface? You can only see the surface. What is another thing which you might see on the surface, jutting in, which will tell you that there is probably a uterus, which sometime you might see in the contrast study also at that area.
So the cervical
A
impression.
cervical impression, right?
Okay.
So
Yes,
you
sir.
may see, you may not see, all of them may not have, but if you look at the histology, they might have uterine morphology, endocervical glands, etc., etc. So how would you approach this now that this child has urinary infections, etc.? Do we need to take it out or we can leave it?
No, sir, we should take it out.
So what are the approaches? Surgical approaches, just list them.
Uh, First, so transperineal approach.
Acha, transperineal, yes, difficult but possible. Transperineal, because this is per rectum. Okay.
Yes.
Transperineal, what else? What are the usual approaches we do? Can we access it from here?
Yes, sir.
Yeah, but it's low down, below the peritoneal reflection. So we have to go deeper there to access it. It's possible. Both by laparoscopy and laparotomy, it's possible. That's one. Where else?
Yes.
Is it, what are the other approaches?
So like transurethroskopic, like
Transurethroskopy, you can only go in here, but it's difficult to do anything else here.
So anterior sagittal or posterior sagittal approaches. like
Yeah,
the
you
one-
can go as an anterior sagittal transrectal this way.
okay.
You can open the anterior sagittal wall and go in with preparation with or without colostomy. That is one. Or you can even go transvesical and transtrigonal straight in there.
Oh.
So these are all different approaches to this difficult area, right? Okay.
Okay.
So when you are given pictures like this, correlate and say these are not common things. So even if you tell them one of the three, it makes a mark that yes, you are understanding the approach, because they want to see whether you know the approach to radiology and how it translates to your surgical planning.
Okay.
Okay. Okay. So we go on to the next. I think we have done this earlier. Yeah. Yes. I'll take this off. Yes, someone please take this. Can you see? Are you able to see?
Yes, sir. We are able to see.
Yeah. Someone please take this. Volunteers. Come. We have lots of participants. Let's have some volunteers. Come.
Sir, I'm Dr. Abhishek, sir.
Yes,
Narayana.
Abhishek.
Yes.
Go ahead.
Sir, this is a CT film, coronal section, which is
Yes.
right upper lobe cystic lesions.
Don't straight go on to the finding. When you describe, you say, you started off well, saying that it is a CT. Yes, it's a coronal section, correct. It is centered well. And then you say everything else, what you can see. You can say that the bony cage looks sort of symmetrical. Then you go on to say the left lung field looks normal to me. Then go on to the right side and describe it in detail. The cardia looks okay, large vessels, roots, you can see they look normal grossly, and then go on to this. Okay, now describe this.
Sir, this is a well-centered CT axial section.
Coronal, you just said coronal.
Coronal section. Trachea appears center, and the bony cage also appears normal. The left lung field is normal, no abnormality seen. Cardia is there is no deviation of the heart to any side. It is present on the left side.
Right.
And-
Come to the lesion now.
Sir, on the right side, on the right upper lobe, there is some cystic lesion seen.
Hmm.
Can be a CCAM
Okay.
or duplication cysts.
Okay. How did you come to that diagnosis? I would say that this is, I would describe it more. This is thick walled. It looks like one big loculus. I cannot clearly see septa in between.
Yeah.
And it occupies almost the entire upper lobe in this section. I am not seeing any adjacent parenchyma nearby. Then in the middle, right side, you have the middle lobe. In the middle lobe, there is some adjacent consolidation sort of picture which is seen. The lower part looks normal. So I would complete all this and then say my differential diagnosis. So a thick walled, almost single loculus, etc., peripherally placed, not towards airway. So what would the differential diagnosis be? We have not given you any more information. Suppose I give you some more information, then you can base it on that information.
Can
One is CCAM, what you were saying. One
Yes.
is CCAM, and if it is a CCAM, then it is a macrocystic, a large cyst, sort of airway malformation, where there's one dominant cyst and maybe other smaller cysts, which we are not seeing in this section. So that is one. What else?
it can also be a necrotizing pneumonia.
Yeah, it can be a necrotic wall, a shaggy abscess wall, etc. That is also possible, right? Then something else, right upper zone, apex,
Identity.
tuberculosis.
Yes.
Yeah, so common things you should not forget. Tuberculosis. After all this, then you can entertain other possibilities. We have not given you other pictures. So maybe you said that it is, if it could be a duplication cyst, etc. If I had given you some coronal, sagittal and other pictures, lateral views and all, then you had seen it as in the posterior mediastinum, maybe you were justified in saying that. But just with one thing, that need not come so high in the differential diagnosis. Okay. So tell all the common things first and point out the limitation of the picture that you have been provided. You can only read as much as it's shown to you. You can't read more. Understand? So how would you, what other views would you like to see in this child?
I would like to see axial lesions.
Yes. Yes. Axial and other sagittal cuts, coronal cuts, you would like to see more to get at the differential diagnosis. So suppose let us let me tell you that this was a tuberculous thing. Finally, this child was positive, and this was a tuberculous cavity. So how do you proceed? It's an infant, a year or so.
Then we should be starting on anti-tubercular therapies.
Yes. Okay.
We should observe the child.
Okay.
We should do any intervention as of now.
Okay.
If there is any deterioration requiring intervention, then we should intervene.
Okay. What are the likely complications that can happen in such a cyst there occupying that full thing?
We can develop bronchopleural fistulas.
Yes.
Develop
What else?
sudden pneumothorax.
Pneumothorax. Okay. Pneumothorax in this thick wall thing is unlikely. What else can it develop besides eroding into the airway? Where else can it erode into?
Can erode into the major vessels.
Vessels causing hemoptysis, etc.
This.
Okay. Right. You are familiar with the ATT schedules, our national ATT schedules? One or two common things which are used in tuberculosis treatment of children, you must be familiar with. The 6-month schedule, the 9-month schedules.
Yes, sir.
Okay. Okay. Right.
I think
Go
should tell
on.
aspergillosis also.
Yes, yes. Necrotizing, he mentioned it as just necrotizing. There are so many things in necrotizing which you can have, including a fungal thing. That's one common area for fungal infection. That's what sir is saying.
Yes.
Okay.
Thank you.
Okay. Are you able to see this? Let me turn it. Okay. Are you able to see? Anyone? Are you able to see?
Yes, sir, we're able to see it.
Okay. So this is a 2 months old child who had a contrast enema, and after that this was the appearance. Was being investigated for Hirschsprung's. So I've given you the diagnosis what he had, but I want to know more about this X-ray. Yes, let's have volunteers, not the same people again. Someone else please volunteer. Doesn't matter what you say. It's just to initiate a discussion.
Sir, there is no flow. It's a barium enema, which is showing
Just
no
identify
flow.
yourself.
Yes, a Tejasvi, sir, CMC.
Okay, good. Come.
So there is no flow. There is a barium enema study of a child.
Yes.
There is no enema shows filling of the rectum, sigmoid, and the descending colon up to the splenic flexure. There's no flow of contrast beyond the mid transverse colon. And there is, I'm not sure, the calcification or a reticular pattern of.
What is all this in the background? What does it look to you like?
It's either a dilated.
No, yeah, you can see here some dilated bowel. Till here you can see
Yes,
it's
sir.
narrow and then some dilatation,
Yes,
but since it's not filled well, you can't comment on that. So
Yes, sir.
you probably there is something here, but we don't know. I wish it had filled. But instead of filling the bowel, what else has happened?
Barium peritonitis.
Yes, it has
It is
somewhere it has
perforated.
perforated and we have
Yes.
barium, whatever, contrast peritonitis. And in this case, we had used barium and that is a barium peritonitis. So what is barium peritonitis and what are the problems with barium peritonitis?
So barium peritonitis, itogenic, this is itogenic barium peritonitis. So when the child requires surgery, it will be, it can lead to adhesions.
So after you've done this test and you find this has happened, what is your approach? We'll leave it for a few days, few months, or do you need to go in?
I think we'll need to go in immediately. So the more
Yes.
we leave, I think the more adhesions it
Yes,
forms.
it's
So.
a very, very bad peritonitis and becomes a very purulent adhesive peritonitis. So you need to go in, clean, etc., and then do whatever is necessary to be done. Okay.
So you must ask whether any pilot film was done before the barium enema was done, you know. You have to be very careful as residents. You should not do barium enema without a pilot film. What is the perforation and then you do. Now, whether
Yes.
the perforation has happened because of the technique of doing the barium enema or already there
Or was it already
perforation.
there?
Yes.
Already-
How else does the pilot film help?
It will
How else
pouch
does the
colon, so
pilot
you
film
can
help?
roll out.
When you are doing a Hirschsprung's thing, how else does the pilot film help? It tells you a plain X-ray always tells you, gives you some idea where the transition is.
The gas, the rectal gas.
Yeah,
And
rectal or wherever the transition according to the plain X-ray pattern is. So that gives you some inkling at what to expect.
Okay.
Okay, right. Fine. We go on to the next.
Barium peritonitis is very got high mortality, you know.
Hmm. Sorry. Yes, will someone take this? Oops, sorry. Yes. Are you able to see? Yes. Yes, someone take this. Should I start off? This is a plain X-ray.
Sir, Sheshadri from Indira Gandhi.
Yes,
Hello.
please. Your name?
Sheshadri from Indira
Yes,
Gandhi.
Seshadri. Please.
Sir, this is a X-ray abdomen, probably erect X-ray, plain X-ray abdomen, also showing the lower chest, which are showing multiple dilated small bowel loops, sir, with
Yes.
multiple air fluid levels.
What
And,
small bowel are you seeing, Seshadri?
Sir, it
What
looks
small bowel?
jejunal as well as ileal loops, sir.
Oh yeah, both are seen. There are some which are featureless and some which have valvular conniventus. So you must specify. It says that you're looking for detail. Yes.
Okay, sir. And then in the right iliac fossa, sir, there appears to be a calcific focus or some focus is there, sir, in the
Yes.
right iliac fossa.
Yes. Good.
And the liver, just above the liver, sir, there appears to be a minimum pneumoperitoneum. I'm not
Yeah.
very sure about
Okay.
it, sir.
Okay. What's your diagnosis?
My diagnosis with this, sir, with perforation and a small bowel obstruction with some calcific focus in the RIF, probably will be appendicular perforation.
Yeah. So that's probably the common thing that can happen. Tell me another diagnosis. Suppose a similar thing you see in the newborn period. Another diagnosis.
Newborn, sir.
Calcification here and this pattern, hardly any levels here.
Meconium.
Meconium.
Meconium peritonitis.
Meconium
Meconium
perforation,
ileum.
peritonitis perforation. So this was of course appendicular. It was in an older child, an appendicular perforation. So approach.
So approach will be initial stabilization of the patient,
Yes.
fluid resuscitation, routine investigations, including CRP and if needed VBG, sir, if the child is sick, cross match for blood and
Okay.
plan
So you are planning to explore, right? You are
for
planning to
exploration, sir.
No, you are planning to explore or are planning
Yes,
to do
sir.
what?
After
After?
stabilize the patient, sir. Suppose the child is, sir.
Go on.
After stabilization, sir, suppose the child is improving, then we can plan for an exploration, sir. Otherwise, we can plan for a temporary measure like a drain. And improve and
Okay. If the
then
child is too sick, you might give a drain, but finally you will have to go in and wash and do whatever you have to do inside, isn't it? If the child is very sick, of course, you might temporize it for some time. That is different. Okay.
Thank you, sir.
Yes. Yes,
Obviously,
sir.
good.
Yes, please. Anyone? 2-year-old child with a poor stream and urinary infection. Anyone? It's avoiding cystourethrogram.
There's a air fluid level in the bladder,
Yes.
filling defect in the bladder.
Where's the filling defect? You're
So
talking
air
about
fluid,
air
so
fluid
at the
level.
dome, yes, sir. Yes, air
Yeah,
fluid
this-
level at the dome of the bladder.
Okay, this you said.
The bladder contour appears normal. There are no
How before you
travaculations.
go further, how can this air fluid level suddenly come like this?
Sometimes normally also during MCU while filling
Yeah.
with
Okay,
air
you
is
might
pushing
have
in, it's
injected.
happening.
That is what.
Okay.
It's not-
Right. So pathological condition we are not talking of here. It can be right. Fine. Go ahead. Describe.
Bladder contour appears normal. There are no travaculations, no circulations. Posterior and anterior urethra appear normal.
What about bladder size?
Bladder size.
Size.
You think
2-year-old child, sir.
Yes.
urethra is normal, doctor? How you can say urethra is normal?
It's not, does not appear smooth, but
Is the urethra dilated?
yes.
Then how
But
did
there's
you say
no obvious,
normal?
but you posterior and anterior, it's almost uniformly dilated.
Yeah, so you describe that. If this is the posterior urethra, this is the anterior urethra, all this looks large, isn't it? The anterior urethra looks
Yes,
as
sir.
large as the posterior urethra.
The posterior urethra.
So that means it is dilated all along here, right
Yes,
till
sir.
somewhere there.
Yes, sir.
Then you see a narrow stream.
Okay.
All this is
Anterior
dilated.
urethral.
And then this is the bladder. So you didn't tell me about the capacity of the bladder.
So normally we fill up to the sacral promontory during MCU.
Correct.
We
So
calculate according.
yes. So when I give you a spot film like this, you say, I am not sure whether this is a film taken in the middle or somewhere because this is a voiding
Yes,
film.
sir.
So I cannot
Yes,
comment on the bladder size.
Size.
in this. If I were given
Yes.
a end filling film or etc., then I would be able to comment, and normally it rises till the brim of the pelvis. That's a normal.
Pelvis.
So if
Okay.
you say that, then they know that you have an idea practically about how to interpret. Okay. Yeah.
Okay, sir.
Then come back to Sir's question about the urethra.
There's a uniform dilatation of posterior and anterior urethra up to
Yeah.
almost the end of the
So what
anterior
is the
urethra.
differential?
It can be the dilatation is usually proximal to the obstruction. So anterior urethral stricture or.
Yeah. So there is something here. Either it's a stricture or it is it's a stenosis, it's a valve, etc.
Meatus
There is
stenosis.
something in this. So how would a valve appear like, and how would you diagnose? Now, what would the next step be in diagnosis?
So cystoscopy.
A scopy. Okay. Right. What else are you seeing in this child besides this? Are you seeing
Sir, his
something else in the background?
bone.
There are a lot
No,
of
sir.
fecal shadows.
Yes, sir. Yes, sir.
Yes.
Fecal loaded bowel.
Yes, that is
Constipation.
significant. You must mention.
Okay, sir. Sure, sir.
If you mention, then they know that you have an eye for all these things to pick up. Yeah.
Yes, sir.
Okay. Yes. Anyone? Please identify yourself and take it. It's a very straightforward one, simple one. What is the study? Come. We have so many participants. Someone take this up. Otherwise, we'll have to go back to Mayur and Apurva. Come on, let's not waste time. Yes, Apurva, you take this, come.
Sir, is this an MRCP study? Like, okay, so this is an MRCP study delineating the intrahepatic and extrahepatic biliary structures, showing uniform dilatation of the intrahepatic and extrahepatic bile ducts, and the right and left.
What does uniform dilatation mean?
This is so not uniform. I mean to say, like the.
No, when you said uniform, you meant something specific. What does uniform mean?
So like if it's like it will determine the type of the colloidal cyst.
Correct. So what did you mean? You mean that something which is maximal centrally and gradually as you go to the periphery, it becomes narrower and narrower. That's what you mean.
Yes, sir.
Yeah, that is a dendritic dilatation, centrally dilated and peripherally tapering. Correct.
Yes, sir.
What does that imply as against non-uniform dilatation?
So this implies it's a saccular cyst, so like type 1.
Does it imply that? It implies that there is an obstruction and the dilatation is because of a back pressure.
Okay.
Whereas if you have the other type of dilatation, chain of lakes, non-uniform, narrow areas and dilated areas, that means
that would mean the type of like cystic lesion suggestive of some.
that is your Caroli disease, etc. Cystic
Yes.
dilatation with chain of lakes appearance. So that is what you mean by your progressive tapering, central dilatation, and this sort of non-uniform dilatation, right? So this is dendritic dilatation, which is tapering towards the periphery. So what is the type of colloidal cyst or congenital biliary dilatation here?
So it's a fusiform variety.
Okay, what else are you seeing? Yes, it's fusiform. This is a gallbladder. What else are you seeing? Or what else will you look for? What is this? What are these two blobs?
So is that the stomach and duodenum?
Yeah, it is. It is. You can see the rugae, etc. What else are you seeing? Very prominently, you can see it. You should have told me about that. What will you look for inside here?
So like intraluminal obstruction or anything.
Right. What else will you look for? Now, what is this?
So like the pancreatopulmonary.
Yes. So why did you not tell me about the pancreatic duct? So that's a pancreatic duct. So do you want to know more? I have given you only one picture. How would you, if you see the films, what would you look for?
So we'll even have to look for the common length of the pancreatobiliary junction, whether it's a long channel, and the further films to look whether it's a stricturous segment, like strictured or pancreatic
How
duct.
high you can rotate the pictures thing on the console and see where exactly this pancreatic duct is coming and joining this area. How high is it? What is the type of pancreaticobiliary malunion? Are you familiar with that classification of pancreaticobiliary malunion? Miano's classification and things?
No, sir.
Okay, so that you must know.
Babbitt's theory. You must read Babbitt's theory.
Yes.
AJPBD.
Once again, what's the name of the classification?
Pardon?
What's the name of classification you said?
Miano, Takeshi Miano has given a classification of the pancreaticobiliary malunion.
Okay, sir.
Yeah. So read the classification of that. Besides your usual classification of the choledochal cyst. You should know about the pancreaticobiliary malunion, how they are classified based on the common channel, the type of malunion, and what implication it has. Right?
Yes, sir.
Okay. Fine.
What is the choledochal fusiform? Form a frustrate choledochal cyst.
Sir, formafrustic choledochal cyst, like it's an attempt for formation of a proper choledochal cyst, but there's not much cystic dilatation, and it's usually associated with a long common channel of pancreatobiliary maljunction, and it has like it's similar to the type 1 variety, but there's not much dilatation, but there's mucosal irregularity and all, and you'll have to treat it similar to a choledochal cyst.
Correct. So in children, when do we say dimension wise that yes, this might be a formafrustate?
Um,
In adults, more than 1
Less than 7
centimeter is
mm.
dilated.
Less than 7 mm is the CBD.
Yeah, so that's that up till 7 we take it, it's okay. More than 7 we say it is probably a formafrustate. It's that transition zone in between, and it's especially more important in formafrustate that you demonstrate a pancreaticobiliary malunion in the MRCP. It will clinch your diagnosis even better that it's congenital biliary dilatation of a formafrustate variety.
yes, sir.
Okay.
Yes. Thank you, sir.
Yes, we are back to you, Mayur.
So this is the X-ray chest AP view. Well centered. I can see little emphysematous changes on the left side.
Okay.
There's a foreign body on the
No, no,
right side.
he's answering. Let him finish. I think Mayur is answering.
Okay. Yes, sir. Radio-opaque shadow is seen in the hilar part of the right right lung.
Yes, go ahead.
Slight emphysematous changes on the left hemithyroid.
Yeah, you mentioned that there are some hyperinflation here compared to the rest, and the right
Yes.
side, this foreign body is there. What other changes are you seeing on the right side? Based on that,
little
you
mediastinal shift towards right.
little bit.
The trachea is shifted towards the right side.
Okay, a little bit maybe.
Yes, sir.
What about this zone?
Yes, consolidation.
Yeah,
in the
there is
lower,
a loss of volume here. There's a loss of volume here. Not so much here. This is still okay, but there's a loss of volume here. So if there's a foreign body here and there's a loss of volume here, what does it tell you? You must conclude with that sentence so that they will know that you know the differences between the types of foreign bodies.
occlusion of the lower.
Normally, in a foreign body aspiration that is acute, what do you see? Hyperinflation or something else?
Hyperinflation is seen.
Hyperinflation.
But
So
if,
here you are seeing.
But if it is blocking completely, then loss of volume will be seen.
It's more than that, it is a chronicity. If this is a little chronic and it gets blocked, then the air gets resorbed entirely without any air coming in. And you're completing, that's why you get this sort of a picture. So this is obviously a chronic body. So how are you going to be careful when you do this retrieval? You're going to plan for a retrieval, isn't it? Endoscopic.
Yes.
So what are you going to be careful about?
I will be careful in the preoperative. I will arrange for a open approach also if the bronchoscopic approach is not able to remove the foreign body.
Okay, you will counsel them that In case it is too distal and it is a chronic foreign body, you have a problem removing it, you might resort to a removal of the thing in the rarest of circumstances. What else? So what are the problems you are likely to encounter?
Organization of the foreign body
Yeah.
in the bronchus, so it will be difficult removing it. A lot of bleeding will maybe there.
So bleeding, granulation and bleeding and loss of vision. Yes.
Yes.
Another thing, look at the foreign body and tell me another problem that you might have.
So it is pointed. It is a sharp
Yes.
foreign body.
Yeah.
So holding it will be difficult.
Correct. So because the head is pointing that side, holding it will be difficult. What instrument amongst what you have are you going to try to take out this metallic foreign body with? You have different forceps that you use?
Yes, sir. Yes, sir.
So what forceps are you going to use for this? Or any hard foreign body which you have to grasp?
I will use a
metallic
tooth grasper.
Okay, I think your alligator, you have an alligator, no?
Yes, sir.
Optical alligator forceps or whatever. So that's the type of thing you use for this, not the usual peanut forceps.
Yes.
Right. So suppose you are not able to localize it, you are not able to find it.
Yes.
And you have to resort to
thoracotomy
surgery, you were saying.
Yes, sir.
Yeah, so but this is so very medial. How are you going to locate it?
With the help of CM, I will take a lateral film of this.
Okay, so one is direct palpation. You might be able to feel it. Then you might use imaging,
Yes, sir.
CM and other imaging modalities to locate it. And then you might even use open palpation, etc., and an endoscopy to be able to localize it and retrieve it. And where would you retrieve it out through? Would you retrieve it out? Suppose this was little peripheral. So would you retrieve it out in through the airway, through the lung?
If it is peripheral, I will go for parenchymal.
Yeah, most accessible superficial point you can take. Okay, right. Good.
Yes, sir.
Yes, this is a very simple one. We can stop with this. We have one more anyway. Come. Anyone, this is a very simple one. Yes, anyone? Narayana, Vellore, anyone? Come.
So this is Sir Abhishek sir from Narayana.
Yes, Abhishek.
So this is a contrast enema, which is showing altered recto-sigmoid ratio with transition zone. Suggestive of
you again start from one end. You have started from the enema thing, no? So you say it's a contrast enema. Then you say you can see, you start from the bottom.
Yes.
Because everything is seen. The anal canal is seen, the rectum is seen, everything is seen. So you say there's a narrow rectum, and then after that you talk about the rest of the thing. Narrow rectum, and then you see that there's a sigmoid, lower sigmoid, then upper sigmoid, and then what else? Go ahead now. So start from one end, just like in the MCU, you start from one end and go till the other end so that you don't miss any findings. Same way here. You talked about the recto-sigmoid ratio. You are saying that yes, it is reverse. This seems to be larger than the rectum. Go ahead. Then?
So then there is a transition zone between the rectum and the sigmoid, recto-sigmoid junction at the descending colon.
Yeah, it's somewhere here. Rather than
Yeah.
being here, it's somewhere here. So it's probably somewhere in the upper sigmoid descending that you have the transition zone. Probably somewhere here. Because it is still narrow, and somewhere there it becomes large. There. Okay. Right?
And the
Then what else are you
descending
seeing?
colon- then descending colon is hugely dilated.
Yes. And what else does it show?
There's a lot of fecal loading.
Okay. Fecal loading. There are mucosal changes, mucosal folds, etc. that you are seeing besides fecal luminal thing. So this sort of a double contrast image that you are seeing. This is why is this important? This sort of mucosal irregularities that you are seeing. What does it tell you?
Suggest hypertrophy.
Yeah, it says that you see this sort of mucosal changes and all when there is early enterocolitis. If you wait long enough, that will progress to enterocolitis. So we are really scared of those changes rather than just a simple mucosa like this, right? This sort of floccular shadows. These are something to be wary about. So how would you proceed in this child? Let us say this is a newborn. What's your plan?
Sir, first I will try with the rectal washes. Sir. If the child is deflating well, then with rectal washes, then I would keep the child on follow-up and plan for procedures after 6
Okay,
months.
I will, if I were you, I would first ask the examiner, sir, may I know the clinical history first, history and clinical findings. Okay.
Yes.
So
Yes.
that means that you pay a lot of importance to basic evaluation, which starts with history and clinical findings. Then you go on to investigations, etc. So don't jump from here to say that yes, we all know that this is Hirschsprung's, rectosigmoid Hirschsprung's or slightly longer colon Hirschsprung's. But you must go back to getting all information and go in a systematic manner. That gives an idea to the examiner that you are going in a stepwise manner. Okay. Then he will tell you, okay, this is a delayed passage of meconium, newborn, distended abdomen. So then you said, so I think this is Hirschsprung's disease and this is how I will proceed. Okay, right. So your answer is correct that you are going to do washes and then continue.
Then if the child is deflating well, then
Yeah.
call back the child later, sir. I'll keep the child on follow-up and call
Okay.
back at 6 months, 6 to 8 months of life when he's having good weight.
Acha.
Then
And do what at 6-8 months of life?
then I can do a leveling biopsy and
Why do you want to wait to 6-8 months?
for adequate good weight gain, sir.
If a child is, he is born, he is just born the other day, he is 3 kg, he is a term child and he has this thing. So 3 kg is a good weight for a newborn, term newborn.
Want to wait if you want to do single stage surgery. If you want to do colostomy, why you want to wait?
Yes.
So you want to do a single stage surgery?
Yes, sir. I want to do a single
Okay,
stage.
so that is why you said you want to wait.
Yes, sir. Yes.
Okay. Well, single stage surgery, if you want to do in the newborn period also, you can do. That is all right. But you must justify what you want to do. You can say, but don't say that you're going to wait so long, 6 months, 8 months without doing any stoma, anything. That gives you sort of risk of enterocolitis and this and that and all. 6 months to go on washes is quite a lot of time. Right. So either you do a stoma with leveling, etc., in the beginning itself, leave the child and then later do your second stage. Or if you want to do a single stage, then plan it accordingly, not too late, within few months, so that you can go ahead and do your single stage. Right. So which are the children you would select for a single stage? Would you select this child for a single stage or not?
Yes, sir. This child, yes, sir.
Why?
So because there is a proper transition zone which is appreciated in the chondrioma, and it is a short segment Hirschsprung.
That is important. It's a rectosigmoid or a classical or a little more than a classical, which you can access from below if you're trying to do endorectal or whatever. So it is important that you select out those ones which you can wash, prepare, and easily access from below. Of course, if you are trying to do, if you want to do a a primary Duhamel, then it is fine. You can do a primary Duhamel also, laparoscopically, laparotomy, whatever. Fine. So you select short segment and classical Hirschsprungs, rectosigmoid Hirschsprungs for that. Okay. And what are the other criteria? One is short segment, rectosigmoid. What else? Some more criteria, important criteria for a single stage. What must you be very sure about?
If there is recurrent enterocolitis.
Okay, that is a disqualification. So you wouldn't take up those children primarily for a single stage. A bad enterocolitis, etc., which has happened just recently, yes, no. You must have histological support. You must be very sure of your level, because you are doing it as single stage. You don't want to have a failed Hirschsprungs or a wrong leveling, aganglionic pull through, all that. So that's the other thing that which must be there. So these are two important factors that you must have, and of course, technical expertise, etc., etc. But these two are absolutely necessary, right?
Yes.
So just one doubt, like won't the dilatation also matter? The
Yes,
proximal-
yes, absolutely. That's very important. The proximal dilatation. I forgot to say, if the proximal dilatation is too much prohibitive, then like he says, you wait with washes, let it come down a bit, and then you can plan for your single stage. Certainly, otherwise you will be jamming the pelvis and it won't work, even if your leveling is correct. Absolutely right.
Yes.
Sir was trying to say something.
Sir,
What are the-
Sheshadri, sir. Sir, one doubt, sir.
Yes, yes.
Sir, you said this might be enterocolitis. So then we may not be correct in going for suggesting single stage.
You
sir.
are not, of course, going to
Neglect.
go in for anything now. You will only give washes till it settles down. Child is clinically fine. Your dilatation, distension, everything clinically goes down. Then you plan to do whatever you want to do, depending on what expertise you have and what histological support you have. Certainly, not with this sort of a dilatation, this sort of a picture would you want to go in to do any drastic major procedure.
Thank you, sir.
Yeah. Okay, I think we've come to the end.
I'll just ask one or two questions.
Yes, sir, please.
What are the other transition zones you see in Hirschsprungs? One is rectosigmoid. What else do you see?
So
Long segment beyond the transverse colon.
Long segment Hirschsprung, where is the transition zone usually? When you say long segment Hirschsprung, where is the transition zone?
Splenic flexures.
Yeah. So that you'll see transverse colon will be dilated and what is the clinical radiological picture in total colonic ganglionosis? What
There'll
is
be a
it?
microcolon.
Question mark sign.
Small left colon.
Very good, question mark sign. Okay, what is neonatal small left colon syndrome?
Infants born to diabetic mothers usually have this
So there also you will get something like long
small
segment
left
Hirschsprung.
colon.
So you must be careful. Correct, well answered. Good.
The history has to be taken well. Okay. So this is the last picture. Anyone?
Sir, it has been zoomed in a lot. Like, can you
Yes.
minimize?
Okay, you just tell me what you are finding. This is a 6-month-old child with a right flank mass who has presented with an asymptomatic right flank mass.
So no, the image, only a part of the image is visible.
Oh, is it? Okay,
Yes, sir.
okay.
That is what I was saying.
Let me, can you see now?
No, sir, actually.
No, not
just-
seeing still. Okay.
दिख रहा है क्या?
Visible on our screen, sir.
Oh, I see. Sorry.
Okay.
How do I cut it down now? You can see this.
No, sir,
image.
it's okay.
It's normal for us, sir. It's normal
Okay,
for us.
okay. Can you read out? Someone who can see, just read out. So what are the structures that you're seeing? Just identify structures.
Seeing the kid, you can see the left kidney,
Okay.
the vertebra, the colon. in
Where's the
front, and
colon? Where's the colon? This?
so that and anteriorly. So
Yes, that's the colon. Then there are loops there. What else? What about this kidney?
yes, a left kidney. Normal.
Correct. But what about this kidney?
So it's contrast enhanced.
Yes, and you can see some dilatation.
Okay.
You can see some fullness of the calyces, etc. Then what else are you seeing? What is this?
Aorta.
Aorta. Where is the other large vessel?
IVC is
Where?
Left renal vessel.
This. That is chinked.
yes.
Appears to be compressed, sir.
Okay, that is compressed. Then what is this?
This is a mass arising from the right kidney, where probably the lower part of the kidney is still normal, but
Yes, there is some little
the
kidney, little thing
multiloculated,
here.
the multiloculated
Multiloculated. What else?
cystic lesion with intervening septa,
There are septae here. And what is this? Solid or cystic?
cystic, sir.
Cystic. So this is cystic. You can compare it with this. You can compare it with CSF. All those things. So this is cystic, septate.
Gross thinning of the cortex, sir.
Gross thinning of the cortex.
Is
Right.
that the lower pole of the kidney that's made out, sir, below the mass?
Right here.
Yes, sir.
What do you think this will be? What is going to come in that position there?
Part of liver.
Part
Liver,
of
it's
liver.
the liver or yes.
Yes, it's a liver. So just to identify the different structures, you must spend time, see numerous films just to identify normal, abnormal, everything. So this is a thing there, a structure there, which is there in the place where the kidney should be. And then you have a little tongue of the liver there. So what do you think this would be?
So based on the age, I think it could be a congenital mesoblastic nephroma tumor,
Yes, but
asymptomatic.
congenital mesoblastic nephroma, do you have septae like this?
Not normally.
They're usually homogeneously
Yes,
dense
sir.
masses.
Yes,
Okay,
sir.
what else can this be? 6 month?
Polycystic.
It can be a MCDK, but
Okay.
again, you won't have this.
Okay, so MCDK are smaller masses, but it is possible
sir.
that one odd mass is a large mass, and septae may or may not be there. That's possible.
Yes,
It is still commensurate with that. What else? A cystic Wilms.
Yes.
A
Or
cystic partially
CPDM.
differentiated Wilms.
Yes, sir.
What else? Which is something which replaces the kidney there. Other cysts of the kidneys, multicystic kidneys, but not
Polycystic
dysplastic
kidney.
type.
Polycystic kidney disease.
Okay, polycystic kidney, will it be? I was waiting for that answer actually. Will it be polycystic kidney like this? How are polycystic kidney? ADPKD, ARPKD in newborns, how are they?
Usually periphery.
They are not enlarged ones. They are, and they they are always, they have multiple microscopic cysts. They are hyperechoic, isn't it? So they don't look like this huge large cysts. Other type of solitary cystic, partial unicystic or multicystic kidneys can be there, but not the usual genetic variety of autosomal recessive polycystic kidney disease, right? So that what else would it be? Inside the kidney, displacing the kidney. Suppose I tell you these are calcifications, this and this.
So cystic nephroma.
Yeah, the cystic nephroma is one thing. What else?
Ossifying renal tumor of infancy.
Okay, renal teratomas, they're uncommon, but renal teratomas also can be there. Renal teratomas, intrarenal neuroblastoma, those are all very uncommon. You should not tell them in the first instance at all. You should tell all that what you have discussed. Those are the common things. Okay, thanks. We'll stop here. Any questions? Sir's there, you can ask some questions if you want. So many other participants are also very quiet today. So next time we will see the names of the participants and call out so that everyone participates. Doesn't matter if you are not exam going also, you learn to just vocalize, verbalize, and take part in the discussion.
Sir, I had just one doubt.
Yes.
Sir, like just in relation to the kidney, that's why, like while looking at the renal scans, so like
Yes.
what is the difference between a renal transit time and a calyceal transit time? I didn't.
So are you talking about diuretic renogram?
Yes, sir. Yes, sir.
Okay. Let me show you a diuretic renogram. Then what I have here. Looks like we don't have a diuretic renogram in this. There was another last time. Okay. Sorry, I don't think we have a diuretic renogram here. Maybe we'll take it up the next time.
Okay, okay, sir.
When we
So,
do, we'll take. Yes.
one doubt. So, in imaging, if you had to differentiate between CMN and cystic partially differentiated, would just solid areas be the only criteria?
That is
Like-
one important criteria. CMN is homogeneous.
Okay, sir.
Cystic partially differentiated, because it's partially differentiated. Some areas are cystic, some areas are solid. You might have calcification, you might have septate, etc. You might have a enhancement of different types. So that is not there in
CMN.
CMN. CMN is dense and uniformly enhancing generally.
Okay, sir. Thank you, sir.
That is how we, and it's a very regular tumor, and the entire kidney is usually involved in the CMN.
Okay, sir.
Whereas
Okay,
veins
sir.
can be one part also.
Okay, sir.
These are
Okay.
common differences. Of course, each can have variations. These are
Okay, sir.
common
Thank you.
differences. Yeah. Okay, shall we wind up?
Yes, sir.
Thank you. Thank you, sir.
Thank you.
Thank you, sir.
You're all done well. Good. Keep it up. All the best for your exam.
Thank you, sir.
Thank you, sir.